Uh, Hi, welcome everyone on board. Actually, um, today we will be just trying to discuss some tricks to prepare or target any uh, oral examination. Okay, so there are certain things which actually, when we are studying, when we are reading some topic, uh, if there is the question is being asked in written exam, the basic difference is that now there is no two-way communication. So whatever you're writing, even if you have written half correct information and you don't know the reasoning for certain things, even then you may not face any problem, and you will be able to pass the pass the question. But when you are appearing in oral part, the difference is that you need to be very accurate, and you should be ready for any counter question. Okay, because if they ask a counter question and you are not able to explain the question, the answer which you are telling, then you will be stuck. You will be stuck, and not every part of world have very structured way of taking the exam. Okay, so this in this discussion I will just try to figure out what should be your approach while answering a question being asked in oral examination. Okay, this is true that I will be telling the general principle. Of course, there will be certain differences when you once you are appearing in an academic exam, or you are appearing in some interview evaluation. So there will be a little bit difference, but here I will be just focusing on telling you the general principles. Okay, just give me a second. So usually whenever any question, usually in the oral part there are two sort of questions. One is scenario based, okay, and other is direct question about any topic, any specific they are asking anything specific about any topic, or they are asking some theoretical thing, like they are asking any definition. Okay, or they are asking some guideline, if specific pinpoint thing. Okay, so first of all we will just try to have what you should be doing in the scenario based question. Okay, so I will suggest you that all of you should have a pen and a white paper with you. Okay, and if they don't, sometimes they provide it. Okay, but if they don't provide, you can ask them, and if you don't have, so what will be the advantage of it, that when they are telling something, there may be a communication error. Okay, they are saying something else and you are getting something else, so there may be a communication gap which may lead to problem. Okay, so this will be like, for example, I'm telling you there is a 35-year-old female, okay, known case of myasthenia gravis. So if you make notes like this, female, shorthand, okay, 35, young, and mg. Okay, so try to note down the data whatever they are telling, because once you are writing this, and don't waste so much time. Even maybe you can write in a way that you are writing and you are looking at the examiner, even you can do like that. It is just that your brain, when once you are writing, your brain will be thinking about it. Okay, so this will help you in organizing your answer when you are starting to answer. Okay, so this is first tip, that note down the data, whatever data they are telling you. Try to note down important thing about that data. This is one thing. Okay, The other thing will be that usually in whatever scenario you are, usually for table viva, which is being said in some part of world, and they are saying short cases. Okay, so there is usually 4 to 5 minutes they have for one scenario. Okay, so if you just waste too much time in using the word that I will take history, I will do examination, you will waste a lot of time. Okay, so if they have given you information about diabetes mellitus or hypertension, so your brain should be thinking that what sort of things are related to it. So you can use your mind will be, you will be using this word, which I will give you hint, that you use the word evaluation. Okay, I will be evaluating the patient on the basis of history, examination, and investigation. And my aim will be to see any signs of decompensation produced by the organ involvement of that disease. Okay, I'm sorry, this stilet is not working very nicely. I'm trying to fix it up. Okay, so decompensation due to organ involvement of that disease. Okay, so that may be in only one system or multi-system. Okay, so generally you should be knowing that whatever system you are thinking, like CVS, respiration, usually CNS, liver, you can just kidney, and then I will say homeostasis. Okay, so if you just divide it like this, so you will be at better you will be at better that you will not miss anything. Okay, and you should be knowing that whatever disease is, if there is cardiovascular decompensation, there will be signs of failure, there will be ischemia or arrhythmia, or any tissue you think about it, that there is an endocardium, there is a myocardium, there is a pericardium, so and there is a system flow, there are some valves. So if you want to think that any decompensation in cardiovascular system, you can think in that ground, that whatever happened, the end result will be involvement of any of the thing which I told you. Okay, similarly in respiratory system, there will be problem related to PO2 or PCO2. Okay, and the problem is either because of gaseous exchange or some mechanical problem. Okay, so if you just try to figure out in when you are reading any disease with reference to oral part, try to figure out, and you will figure out 4 or 5 things in every disease. Okay, so if you follow this pattern in your mind and just practice few times, you will be in a better shape. Okay, so evaluation on the basis of history, examination, and relevant investigation. Okay, so at the end, then you will be checking out the risk factors. The next step on the, like you saw everything, and now you are assessing the risk. So you can say, what are the cardiac risk, what are the pulmonary risk, what are the renal risk, what are the problem to the liver, what are the problem to do to the and then this is the main risk. And then according to your anesthesia, because whatever you are doing, either your end result will be in the induction of the patient, in the maintenance of the patient, and in the recovery of the patient. Okay, in the induction, you whatever steps you are doing, something related to the airway, or if you are performing some regional, so this will be the induction. And maintenance will be like after giving regional or after giving anesthesia, how you are maintaining it. Okay, so in maintenance, or even in, for example, airway, you will have to use some induction agent, and you have to use some muscle relaxant. So you should be thinking critically that in that disease, is there any problem in induction? Is there any problem in airway management? Is there any problem with inhalational agent? Do's and don'ts. Okay, so if you think critically, you will be finding some things in some things. Okay, so related to airway, either it is the use of muscle relaxant, This is one thing, the risk of aspiration. This is other thing, and you are having difficulty in managing it. Usually these are the things which you will be thinking. Okay, so whatever you are your induction plan will be according to that disease. You just should be rationalizing it, that is there any problem with the airway, sorry, any problem with the muscle relaxant you are giving, the risk of aspiration, difficulty. Similarly, you should be thinking that in the maintenance any problem it may be related to it. Okay, and then another thing which will be very important, that what monitoring you are doing. So whatever their scenario they have given, you should be thinking about these things: monitoring, okay, then fluid, then analgesia. Okay, so these are the things, and then there is a problem related to recovery is PONV. Okay, and you have a post-op analgesia plan. So these are the things, whenever they are asking you any scenario, please divide your answer or think in that way. Okay, so just to recap what I told you, and then there will be this will be one thing which should be in your mind, and another thing which you should be thinking is you have to make a preoperative. In preoperative, any optimization needed, any referral needed, okay, and any preparation, logistic preparation, or any preparation you want to do. Okay, then you can think that, like for example, if you have a patient with the diabetes, so one of the thing in the preparation is to control the blood sugar and convert the oral medications to IV medication. So this you can say a preparation. In optimization, if you have a patient with COPD, so your optimization is that you are trying to have the reversal of target the reversible component. That will be that you are giving some antibiotic, you are giving some steroid, you are doing chest physio, you are doing incentive spirometry, you are giving some bronchodilators, you are giving some mucolytics, you are doing some postural drainage with physiotherapy. This is and you are treating the heart failure, which is due to cor pulmonale. So this is example of optimization. Referral, that you need involvement of any other specialty. Like if you have in the exam scenario, they have given you, we have a patient with hemophilia, or we have a patient with the thalassemia, or we have a patient with the sickle cell disease. So the referral is hematologist. If you have a patient with rheumatoid arthritis, the referral is to multi speciality, because this patient is taking medications which are mainly affecting a number of systems. So maybe there is need of pulmonologist, there is need of cardiologist, there is need of rheumatologist to optimize or get some juice out of it. I am using this word, that whatever reversible thing you can do. Okay, so this will be one thing. And intraoperatively, I have told you whatever things you are, and even in preoperative preparation, this logistic preparation, anything specific you need in the operation theater. Like if you have a pediatric, we have repeatedly discussed about it in our sessions, and you have to check about the special equipment, medications, prevention of hypothermia. Okay, special equipment needed, special tables may be needed. Okay, so these special circuits may be needed, laryngoscope blades special needed, you have to take smaller syringes. So this is a logistic preparations for a pediatric patient. If you have a very obese patient, now you need a bigger table. You need too many people to shift the patient. Okay, you need to make the ramp position to achieve the intubating conditions. So whenever you are answering that question, you have to keep this thing. And this is, you see, whatever scenario they are asking. Okay, now I will come to the other aspect. Similar thing you will be doing intraoperative and then post-operative. You will be planning for any anticipated complication, and post-operatively where will be the place. Is the patient going day surgery? Is the patient going to ward? Is the patient going to HDU, or is the patient going to ICU? This will be your planning in the preoperative period, and then you will be according to whether you are keeping the patient intubated or you have to extubate. In extubation, you have to similarly in the airway management, I missed this thing, laryngoscopic stress response. This is a big thing. So similar thing will be there at the time of extubation. So how to blunt it, okay? And then in the post-operative period, what complications you can face. So this is another way you should be, you have to, in the scenario-based question, you have to see, and then you have to divide it in patient-related factor, disease-related factors, anesthesia-related factors, and surgery-related factors. These things are actually interconnected, but patient means demographics, okay? Demographics will be like its age. If you have an elderly patient and you have a young patient, things will be different. If you have a neonate or a pediatric patient or elderly patient, things will be different. Sex, okay? Like in different, like female or male, there are certain consideration you should be expecting in different, in like, for example, a female of 55-year-old female expected to be postmenopausal, maybe on hormone replacement therapy. So you are expecting this thing in female. Similarly, if you have a male, there are, of course, in other parts of world, female and male patient both can smoke, but in our part of world, more of the males will be smoker. So things like that. And then the basic height, weight, okay, or anything related. I'm just giving you example because there is a long list, and we will short of time, and I have discussed this topic before as well. So I will, when I will upload this video, I will share the link of the discussion which we did before. Okay, so anything related to the patient, and then anything related to the disease. Okay, so disease, if maybe they will asking you, but if even if that, what is the main nature of the disease? Okay, whether it is a genetic disease, whether it is a disease related to a complication of something. Okay, what sort of disease it is, what are the organs involved. Okay, what are the organs involved, and another important thing will be what are the medications or treatment, whatever, like not use the word medication, management. Okay, so there will be something related to the management of the patient. So the one will be systemic involvement, what is the nature of the disease, and one is the medication or management patient is taking. So this is will be related to the disease. Okay, and anesthesia related, I told you there will be, first question will be GA versus regional anesthesia versus combination. This will be one thing. Okay, in regional, the central neuroaxial block or compartment block or peripheral nerve block. Okay, and then I told you the different steps of general anesthesia, if whenever you are. So these will be things, and there will be anything which is affecting the management, affecting the airway, affecting the regional, affecting the fluid, affecting the medications. Okay, affecting the equipment. So anything related to anesthesia you have to think. And then third thing will be surgery. Okay, that what sort of surgery it is, usually how urgent it is, urgency of the surgery, risk involved, whether it is high risk surgery or low risk surgery or anything like that, bleeding risk, specifically bleeding, how much bleeding you are expecting. Okay, and then what position surgery is happening, what sort of incision surgeon will give. Okay, and any critical step. Okay, like for example, I'm give you example that if there is an orthopedic surgery, so there is a thing which are different will be tourniquet, things will be bone cement or embolism, fat embolism or pulmonary embolism. Okay, so this will be related to the specific sort of surgery. Incision, whether the incision is laparoscopic or whether the incision is open. So this will be a critical thing, that the technique they are using, the approach they are using. Okay, so this will be the thing which you should be concentrating, and then it will be easier for you to answer. I have just channelized this thing in some files. So if you go there and then this file, how to study, and then okay, So whatever things I have told you, yeah, this is a. Are you people with me? Are you understanding? Is it helpful?
Yes.
Yes, sir.
Okay. So any question in between, please just raise the hand. So as I told you, what is the main category? Okay. What is the main pathology? Okay. Diagnosis, evaluation. Now you think, and I will be ready, Zishan and Sehrish. I will be asking you now. You can look at it and now you can tell. I will give you a scenario. First, Sehrish, you please try. Okay, that you have a patient with the, I'm just trying to be very simple. There is a patient with diabetes mellitus going
Yes,
for
sir.
laparoscopic surgery. So just have a look on this file and just try to organize your answer. There is a 50-year-old male patient, diabetic, going for laparoscopic cholecystectomy.
50-year-old and diabetic. Okay, sir. I would like to evaluate my patient who is 50 years old with comorbid diabetes to see the sign of decompensation produced by the organ development of diabetes mellitus. I would like to elaborate my patient in such a way that there will be disease.
What word I have taught you? Microvascular and macrovascular complications
And
of
optimize
diabetes mellitus in different organs, leading to end organ damage. So my aim will be to see what sort of end organ damage diabetes has done. Okay.
Okay, sir.
Okay, move
Okay.
forward.
After optimizing all that, as the patient is for laparoscopic surgery, I will do certain examination and pre-optimization of my patient, that his blood sugar level and associated complication like airway issues,
What
spine,
end organ damage?
neck.
What or end organ damage you are expecting in diabetes mellitus?
Then microvascular के हिसाब से nephropathy, neuropathy, and retinopathy, and cardiovascular disease में cerebrovascular accident, coronary artery disease, and all these things. And so joint issues, stiffness of joint, airway difficulties due to neck mobility, and temporomandibular joint stiffness. These will be
and because
the difficulties.
This will be the problems. And then quickly how can you check the damage being done? Like for example, if you want to see the cardiovascular system, how will you evaluate? What will you do?
ECG.
Very good. ECG.
Cardiovascular for ECG and echo will be helpful, and for airway examination will be helpful, and for respiratory, chest X-ray will be helpful. And if there is further thing needed according to that, I will do further. And for
like for example, you found a patient.
ABG,
this 50-year-old male is not able to move, for example. Okay, so this will be according to the METs and physical activity. For example, if you have a patient diabetic, apparently he's not saying anything, but you can assess the physical activity because the patient is having osteoarthritis. Okay, so in that case, what will you do? You will go for invasive test. Like for example, you can go for stress thallium scan. You can go for stress dobutamine.
Exercise.
Okay.
Yes, sir.
This is example. You can elaborate further. Okay.
Yes, sir.
And regarding the diabetic control, you told. And how will you see that the patient has a good diabetic control? Because this is an elective sort of surgery, right?
Sir, I will advise her to bring the HbA1c test.
Very good.
And fast blood sugar level test.
Okay.
These two tests.
Yes.
And sir, I will assess the kidney status to see the corticular medullary changes by ultrasound KUB and urine for microalbumin.
Okay, fine. Now you took the patient in the operation theater room. You had converted, you had managed the blood sugar. Intraoperatively, what things you will be expecting and what will you do?
So there will be certain things regarding that is diabetes, and there are certain things related to the surgical procedure, that is laparoscopic. The thing that will be regarding to so the disease, as we have already optimized the patient, so there are less chances, but still there are chances, so we have to be cautious regarding the airway, because anticipated difficult airway is there, increased chances
Well,
of gastric
what word,
aspiration.
what beautiful word I have told you before, that there will be more chances of mortality and morbidity in a patient
Yes.
with diabetes mellitus. Okay.
Yes, sir.
Okay, fine.
What? Okay. And sir, according to surgery related, we have certain issues with the tendon and bird position, and
What have you told you about
uh,
laparoscopic surgery? What I have told you?
laparoscopic gas insufflation issues,
No, before.
physiological changes
No, no,
in
no, no.
the.
Before gas insufflation, I told you three. I'm giving you a hint. Three steps. 3 steps or 3 things related to laparoscopic surgery.
Sir, positioning, monitoring,
Trocar
sensitive
insertion.
drugs,
Trocar insertion.
trocar insertion.
Trocar insertion, 1 step. Number 2,
Yes, sir.
insufflation. When the trocar is inserted, visceral injury, vessel injury. Then pneumoperitoneum, chances of physical effects like tube going,
Perfect.
going to the bronchial. Okay.
Yes.
Problems related to
Yes.
decreased venous return and problem related to ventilation. Okay.
Yes.
Or at the same time, there may be sudden gas embolism because CO2 may enter
Yes.
circulation. And then third step will be gradual music created by the CO2. Okay.
CO2, yes.
So 3 steps.
CO2 system.
Remember in 3 steps.
Okay, sir. Trocar insertion and CO2 insufflation and the. Okay, right.
And
yes, sir.
We missed, if you have a look here. So what special monitoring would you like to do in this patient?
Sir, special monitoring. Sir, arterial line.
Very good. What else?
Arterial line.
You should be monitoring the abdominal pressures.
Abdominal pressures, yes.
Okay. Because there are chances of. Would you like to monitor? Because
abdominal.
Yes.
Yes.
Would you like to monitor the airway pressures?
Yes. Yes, sir.
Because when they are doing the pneumoperitoneum, after that the airway pressures may increase. Okay. To optimize the ventilation. Would you like to specially, of course, you monitor this in any patient, but more important here is end-tidal CO2, because there will be more PCO2. So you have to optimize the rate so that the CO2 is washed out.
Washed out, yes.
So just have a look here. Any other thing? Pre-medication would you like to give in this patient?
Pre-medication, sir. Antibiotic prophylaxis, IV hydration.
What else? You said that there is risk of aspiration. So would you like to give acid prophylaxis?
Oh, yes. Yes, sir. Yes, sir. Unparticulate sodium citrate and H2 receptor blocker.
This patient is diabetic. So would you like to give some anxiolytic?
Yes, sir. Diazepine.
Is this patient at risk of, because, okay, what analgesia will you give?
Analgesia, sir, we have multimodal analgesia choices for this patient, like paracetamol and NSAIDs, and light opioids like fentanyl, and we can also perform regional block at that point of trocar insertion.
What is that? Regional anesthesia?
No, sir, not regional anesthesia. Local insertion of the
Local
lidocaine at the
infiltration,
point of
local infiltration.
local.
And another important thing here will be that you have to take care because of, have you heard what is the cause of shoulder tip pain after laparoscopic surgery?
No, sir.
Shoulder tip pain
So
is
this is
because of diaphragm irritation. Okay.
yes, referred pain. Yes.
Referred pain. Okay. So they just infiltrate some local anesthetic. This is one thing.
Okay.
Then for analgesia, why are you not saying tab block?
Oh yes, tab block, sir.
Okay. Multimodal
Yes,
analgesia. One will be, you can tell, now it is the material is in front of you. Now it's up to you how to answer your question. You can tell about that diabetic patients have tendency for neuropathic pain. Okay. They are at risk
Yes,
of
sir.
developing post-surgical, chronic post-surgical pain. So as a part of preemptive analgesia, we can consider to have gabapentin. We can give paracetamol, and we can give NSAID. If the renal functions are not deteriorated, we can even start this thing as part of multimodal analgesia plan as a preemptive analgesia. Okay.
Okay.
So intraoperatively, I can give some if available according to the availability of the opioids. We have fentanyl or remifentanil. We can give in infusion, or whatever the availability is. We can give morphine. We can load the patient on morphine, and post-operatively alongside this tab block or subcostal block or quadratus lumborum block according to the port inserted. Okay. Then
Yes,
in the top of it, you can have a PCA morphine or PCA fentanyl.
Yeah.
So this is a default answer which you can use for any analgesia care. Okay. Whatever surgery is, you can just slightly modify a little bit, and you can give that. I can give preemptive analgesia with gabapentin, paracetamol, and NSAID if there is no contraindication. I can give some this one intraoperatively. I can give some paracetamol. I can give some opioids, and there are some other techniques or other things which are being used frequently to blunt the stress response, like in the form of dexmedetomidine infusion, like in the form of lidocaine infusion, like in the form of very low dose of ketamine infusion, which has been used successfully recently. You can use this word. Okay. Like titrated according to the response. Okay.
Okay, sir.
Okay. So muscle relaxant of choice in diabetic patient, anything specific?
Sir,
Nothing specific. Nothing specific. Okay. The maintenance you will maintain by any inhalation agent.
Inhalation.
Okay. Fluid therapy and diabetic control. You have to tell this thing, because I told you that important thing. Yes, I missed that thing, is point of care testing. Okay. Any surgery will have, what do you mean by point of care testing? That the test which you do on the bedside during intraoperatively or in the ward, the tests which were being performed, we discussed before, there are a lot of point of care testing. So here you can say you have to check the blood sugar, frequent blood sugar. Okay.
Yes.
And you have to titrate according to that. Either you are giving IV or infusion or subcutaneous. Subcutaneous route is not very advisable in intraoperative period. Okay. So that's how, if you practice, you just keep this paper in your hand and try to fit any disease, and I can guarantee you the examiner will be not able to ask you anything else. What else? You just think about it. Cardiac risk. There is risk of MI. There is risk of arrhythmia. There are risk of ischemia. There is risk of heart failure, pulmonary risk. This patient, because of diabetes, this patient is at risk of more infections. Okay. This patient is at risk of AKI if there is chronic renal failure on top of that baseline renal impairment, and that it can be precipitated by the surgical stress, decrease in renal perfusion because of any reason. And if you use too much NSAIDs, then it can cause So this is a renal risk. Aspiration risk, as I told you, if it were a female patient, the risk would be even more. That female gender, opioid use, and there are certain surgeries which had more
Yes.
risk. Wherever there is involvement of vagal nerve, there is more chances of PONB. Okay, so laparoscopic surgery is one of
Yes.
them. Airway management, I told you that because of glycosylation of joints, there may be problem in the laryngoscopy and intubation. Okay, special monitoring needed, invasive blood pressure monitoring, as and I discussed.
Yes.
Okay, blood transfusion usually
Yes,
not.
sir.
Usually, if it is
Yes.
baseline not, but you will be, because that patient having risk of cardiac problems. Okay, so you will be targeting blood hemoglobin more than 10. Okay,
10.
that's it. And one thing we missed, that at the time of induction, diabetic patients are at more risk of hemodynamic instability, roller
Yes.
coaster phenomena. At the time of
Yes.
induction, if you give too much dose, suddenly the blood pressure will fall. Then you are doing the intubation, then again blood pressure will go up. Then you increase the depth of anesthesia. Before incision occurs, positioning, again blood pressure will go down. Okay, then you again decrease the anesthesia, and then they give the anesthesia incision, then again the blood pressure go up. So this is called as roller coaster phenomena. Okay, go
Yes.
up, go down, go up, go down. So the person who have a ride in roller coaster, they know, they can understand what is roller coaster. Okay. Zishan, anything would you like to add? Zishan is here. Okay. Okay, so that's what I told you before. Evaluation on the basis of history, examination, investigation. Risk assessment and stratification. Stratification means that you are preparing yourself or you are trying to reduce the risk. Okay, and optimization of any medical condition if it is there. Okay, and anticipation of complications, like you should be having atropine or glycopyrrolate ready with you, because in this
Yes.
there will be chances of bradycardia. Okay, and as I explained to you, planning of all anesthesia steps, maintaining homeostatic conditions, like homeostatic condition will be maintaining oxygen, maintaining CO2, maintaining volume, maintaining temperature, maintaining rhythm. Okay, maintaining acid base status, maintaining volume status, patient is having good urine output. These all are called as homeostatic conditions. Okay, so I just made this very weird sort of mnemonic. Okay, uh, you just try to make it and fit it in your answer. Your answer will be much better. Okay, you are doing evaluation, certifying it, anticipating it. Okay, so the next step is this one, pre-operative, intraoperative, post-operative, and that's what I told you. Peep into the different surgeries: surgical urgency, surgical risk, bleeding risk, patient position required, usual duration, level of incision required, level of anesthesia required. Okay, uh, the example, for example, if the surgeon is doing nerve monitoring or doing evoke potentials, for example, so you will be taking care of it. This is one example. Okay, if they are wanting hypotensive anesthesia, or if they want you not to give muscle relaxant. Okay, or not to use inhalational agents, as in case of, for example, neurosurgery, where they want to use minimal, or no, they can ask you to use tiva, because the evoke potential will be disturbed. So this is the basic. If you understand this thing, your answer will be much better. Okay, so that is what my main aim was, and I think I had one more file. Yes. What will be the rationale of different investigations? Okay, so if you are doing CBC is to see the hemoglobin, hematocrit, WBC is for infection, platelets, especially if you are targeting any regional, but you have to see both qualitative and quantitative. Okay, and this blood smear in specific conditions. Liver function test, if you have any disease involving liver, or any medication which is involving the liver. Light example is anti-epileptics, okay, anti-tuberculous, okay, things like that. There will be big, and either it is the synthetic function, or it is the hepatocellular damage or obstructive function. You can divide the liver functions in three categories, okay. Synthetic function, how will you see, Sarish?
Yes, what sort of synthetic system?
Of liver?
Liver synthetic. Sir, we usually do AST, ALT.
No,
and
no. Synthetic function. Synthetic function is through
So
albumin
albumin or any
or INR.
depth.
INR, okay.
Okay, INR. Okay.
And hepatocellular damage by this ALT, AST, GTT, okay.
Okay.
And obstructive
Yes.
function with alkaline phosphatase or bilirubin. Yes.
Ribbon, yes.
Okay. And renal function test. Okay, renal function test, both in the form of decreased urine output or the quality of urine or quantity of urine, usually. Okay. And these are the things which you will be telling that if the renal functions are not good, creatinine will be going high. If there is urea is high, it is indication of dehydration. Okay. And then you are looking at the electrolytes. You are looking, as I told you, glucose, HbA1c, you told me, coagulation profile, PT, APTT, INR, ACT, FDP's level, different condition. In different conditions, you can have these stats. So you should be having a list of these stats in your mind, and you can tell, like if you want to see the functional status of platelets, so your answer may be CT-BT and platelet function assay and thromboelastography. All will tell how good platelets are functioning. Okay. So yet if you have a patient with epilepsy, you in your answer you should be adding anti-epileptic medications, levels of drug, level of phenytoin.
Levels.
Okay, so this is important thing. Digoxin level, lithium level also in the condition is the patient is taking, because they have narrow therapeutic index. Okay. And similarly, you are doing chest X-ray to see, and there are so many formulas to see the bone, soft tissue, vascular, effusion, edema, cardiac. You can have these things in your mind. Okay. And you can just tell, I'm doing it for this. Like if they ask you why you want to do as chest X-ray in a diabetic patient, what will you say?
So chances of infection?
Infection, edema. Okay, signs of
edema, yes.
Okay, and infection.
Cardiac failure.
Okay, ECG, rate, rhythm, access, blocks. Okay, signs of ischemia, infarction, and then individually, because they can ask you, you should have a concept about it. Okay, that what you are looking at when you are looking in the ECG, what you want to look in the ECG. So these are the things in the step by step. Even in the talks, you will have ECG. So if you think in your mind in that way, that what is the rate, if the rhythm is normal or abnormal, access grossly deviated or no, if there is specifically you are seeing PR interval is prolonged, you are seeing any obvious block or not. Okay, and then you are seeing any elevations or depressions. Okay, is the T wave is tall tented, and things like that. Okay, in the echo, what you like to see, there are some chambers, there are some doors. Okay,
ejection,
and some so you have to see the systolic and diastolic. So systolic function is in the form of ejection fraction, diastolic dysfunction is in the form of relaxation. Okay, and there is a E over A ratio. There is a concept of E over ratio, that how much atria is contracting, like how much heart is depending on the atrial contraction. Because as hypertension, remember one thing, whenever we are being asked in echo, we always say ejection fraction. Ejection fraction is the least important parameter in hypertensive patient in initial stages. So ejection fraction, if it is normal, it's not significant. If ejection fraction is decreased, it is significant. You understand?
Okay.
Ejection fraction, if it is more than 55, doesn't mean that heart is good. You have to see the diastolic dysfunction, and they document it in the form of E over A ratio. Okay, so E over A ratio is telling how much heart in diastole heart is not angry and receiving the blood nicely. Okay. And if the heart is not relaxing nicely, there is more dependence till the time atria does not contract, the heart is not able to fill. Okay. So this is the concept of diastolic dysfunction, that they say that they see that how much component of atrial contraction is there in the heart when they at the end of the diastole. Okay. So this is, so to be very simple, diastolic and systolic both dysfunction. And if there is ischemia, the first thing will be there will be some segmental wall motion abnormality. Then there will be hypokinesia, and there will be at the end, if there is akinesia, and there will be sign of failure, like and then ejection fraction will decrease. Okay, so this is the concept. And then they say the chamber size, chamber pressure, any chamber clot. Like if you have a patient with atrial fibrillation, you have to say that there will be stasis and there will be chances of chamber clot. Okay, and they say the wall thickness. And if they are taking about mitral stenosis, so it is valve size and transvalvular pressure gradient and regurgitant fraction. Okay, regurgitant fraction. And then they say the pulmonary hypertension, they see the pressures, and then it's something important, vena cava fluid responsiveness. Okay, vena cava fluid responsiveness by seeing where vena cava compressibility. So because if you have a patient with hypotension, vena cava is compressible, the patient needs fluid. If the vena cava is not compressible, distended, and you see that contractilities are slightly reduced, so you have to add vasopressor, and then next step will be inotrope. So that's how you target or diagnose your patient with hypotension. Okay, so if the vena cava is compressible, it means the fluid. If the vena cava is not compressible, distended, and so you need vasopressors. Okay, so things like that, signs of heart failure. Thallium scan, it is to see the perfusion defects. Okay, like it will be telling water is going to the area or not, blood is going to the area or not. So dye is not going, there is some blockage. Okay, and then they do the cardiac CT to see it, or they do the angiography. Okay, and then they see the which valve is involved, which vessel is involved. So they do like that. And exercise tolerance test and cardiopulmonary exercise testing is to see the functional capacity of the patients. Okay, so they are saying whether heart is able to pump and whether body is able to utilize the oxygen or not. So in that they say the anaerobic threshold at which that patient is unable to utilize oxygen and anaerobic component is coming. Maximum oxygen utilization in the form of METs. This will be telling you the METs. Okay, and they do it to quantify. Usually they do it in the lung resection and operability. They do it, but actually it is, you can say, the exact representation of to seeing the MET score. Okay. Then pulmonary function test, either it is in the form of the mechanical things or the blood gas analysis, or if there is some obstruction for also for mechanical, like spirometry will tell you whether patient is having any obstructive or restrictive problem. It can be seen in through the flow volume loops as well. And the resulting is, for example, if it is hampering the gas exchange, then PO2, PCO2, pH, bicarb, they will be telling you that lung is good or not. And then lung diffusion capacity. Usually we don't use it commonly, but in specific scenarios like thoracic surgery, they have to do it. And then the sum of other investigation should be showing that in which condition CSF proteins are increased.
Viral encephalitis.
GB syndrome.
GB syndrome.
Okay, so you just should be knowing. And if you have a problem with the muscles, so either it will be you will be doing this nerve conduction studies. Okay, or you are seeing the like either muscles are not functioning or nerves are not conducting. Okay, and polysomnography you do it in obese patients. And then viral markers, you do hepatitis B, hepatitis C, HIV to see the any this one In fact, this will be at the risk of this
Fusion related, sir.
occupation related. Okay.
Occupation.
So there is a concept. They can ask you one question: what are the universal precautions you are using? Okay. So similarly, pregnancy test, tuberculin test. This is for TB. CT scan, whether you see it is extradural, subdural, subarachnoid, either ischemia or hemorrhage. Okay. Usually in CT scan brain, you have to find, and they try to find the midline shift. Okay. Midline shift. If there is midline shift, it is just a sign that there is something wrong. Or extra, if it is epidural, it is concave outward, and if it is subdural, it is biconcave. I always forget this thing. You have to see what is the difference, how to pick in CT scan, extradural versus subdural. Okay. And these tests you do in thyroid. We discussed before, this is just a horizontal, just to keep, and I suggest you to have a printout of this paper. I just, how I did not copy paste it. I have typed myself, thinking, and I have write down everything. Okay. So point of care testing, as I told you, blood sugar, thromboelastography, rotum, ACT, INR, dipstick for urine, like ketones, proteins.
Indeed.
Okay. And okay. And fundus examination is there for hypertensive patient and carotid. Just have a look at it, and it will help you. Okay. So this was I wanted to the people to tell, and then this is actually very good. Just a second. I say this my best friend: normoxia, normocarbia, normotension, normovolemia, avoid sympathetic stimulation, maintain myocardial oxygen demand supply ratio, and you add here, I did not write it here, organ perfusion, vital organ perfusion. Okay. Sinus rhythm, maintain SVR, maintain preload and afterload. You can use the word cardiac filling pressures. Okay. Right side and left sided. And then multimodal analgesia with paracetamol, NSAIDs, opioids, regional, local, gabapentin, and this dexmedetomidine not written here. Okay. So this is another thing. And this is for long case. Actually, this will not be used by you, but you can have a look. And this is what I told you: demographics, medical, surgical, and aesthetic history, previous history, if anything related to it. Okay. And then you will decide whether you have to proceed it or whether you have to cancel it or optimize it. Okay. So what investigations we did, any referral needed, as I told you, medication history and the patient medication taking, if you need to increase, decrease, optimize it. Okay. And then you will be expecting, if, for example, if the patient is pregnant, so you should be thinking that there will be MAC will be reduced, local anesthetic requirement will be reduced. Okay. There will be chances of prolongation of this neuromuscular blockers. There may be like things like that. You will be looking at it in that way. And then every patient try to have a ASA status. When they are giving you that data, just try to create the ASA status of the patient. How much is the METs? And this New York Heart Association classification is for heart failure. Okay. So you can say that this patient may be New York class 1 or 2 or 3 or 4. 3 or 4 is active cardiac condition, and 1 and 2 is clinical risk factor. Similarly, Canadian class 1 and 2 is clinical risk factor, and 3 and 4 is active cardiac condition. Active cardiac condition means like you have acute or recent MI. Acute MI is within 7 days. Recent MI is within 30 days. Okay. And this other active cardiac condition is this, like you have decompensated heart failure. Okay. Or you have active angina, unstable angina. Okay. Or there is severe valvular heart disease, or there is severe arrhythmias, significant arrhythmias. So that will be in active cardiac conditions. You will not do any elective surgery if there is active cardiac condition. Okay. If there is clinical risk factors, then you will be seeing the surgical risk. If there are 2 or 3 clinical risk factors, like clinical risk factors are New York Heart Association class 1 and 2, like compensated heart failure, or angina class, it is 1 and 2, like there is stable angina. Okay. And this one, old MI. So this is also risk factor. And then one factor from brain, one factor from kidney, and one factor from a chronic disease like diabetes. So factor from brain is old history of CVA. Okay. And from the kidneys is creatinine more than 2, renal failure with creatinine more than 2. And this one, diabetes, is insulin dependent diabetes mellitus. So if you have a patient with insulin dependent diabetes mellitus and having creatinine more than 2, or the patient is having any of the active cardiac, this one, heart problems, so you will be doing in further investigations. Okay. And you are doing the stress testing actually. Okay. So one, will you be doing stress testing with correlating clinical risk factor and surgical risk. Surgical risk will be, there are some low risk surgery, like, give example of low risk surgery. Low risk surgery like superficial surgeries, breast surgery, hernia, these are superficial surgeries. Okay. And intermediate risk surgery like body cavities, intrathoracic surgery, or this intraperitoneal surgeries. These are intermediate risk. And high risk surgeries are, for example, aortic surgeries, vascular surgeries, emergency surgery, liver transplant. These are high risk surgeries. Okay. So then pulmonary risk factors, you will be finding a list of pulmonary risk factors, like patient with COPD is a pulmonary risk factor. Low albumin level is a pulmonary risk factor. Okay. In upper abdominal surgery or thoracic surgery is a pulmonary risk factor. Smoking is a pulmonary risk factor. Things like that. You should be knowing what are pulmonary risk factors. So please just find out the list of these risk factors. Okay. So similarly, I have just made it like some, that whenever you have a patient with liver disease, you have to tell that I, on the basis of history examination and investigation, I will see what is the Child-Pugh score. Okay.
Okay.
Because high Child-Pugh score will lead to more mortality and morbidity. Okay. So, and if it is C, I will try to push it, correct the reversible things. Like if you have a patient with CLT, what you can do? You can do the ascitic tab. You can give some albumin. Okay. You can give some lactulose to avoid patient going in encephalopathy, or you can improve the encephalopathy by it. Okay. So you are treating if there is spontaneous bacterial peritonitis, you are treating it with antibiotics. You are giving albumin. You are replacing the coagulation factors by FFPs or things like that. Okay. So this is the correction or improvement. Then C will become B. Okay. If it is B, you have to push it in A. If it is in A, you have to avoid factors which can lead patient deteriorating and going in B. Things like that. So whenever you have a patient with liver disease, you will quantify or target your management in this way. Okay. And then this is specifically for transplant, liver transplant, but you should be thinking this is for acute paracetamol poisoning, and this is for other things, MELD or PELD. MELD is for model for end stage liver disease. Okay. And then spinal cord risk factor, like for example, patient is having hypotension, spinal cord may be affected. Okay. So this is happening in hypotensive anesthesia. And then in every patient, you are evaluating the risk of thromboembolism. Any surgery more than 1 hour, there is more risk. Obese patient, more risk. Pregnant patient, more risk. Previous history of embolism, more risk. Okay. If the patient is having fracture, bedridden, cast, more risk. So things like that. You can have a list of factors for prophylaxis need and thromboembolism risk. Okay. Similarly, is true for PUNV. As I told you that there are some specific age groups, female patient, female gender. Okay. Good news for smokers that in most smokers, this is a prevention against PUNV. So all the people, if they want to have low risk of PUNV, they can start smoking. Okay. So things like that. So there are some surgical risks, like for example, if wherever there is involvement of vagal nerve, there will be more chances of PUNV. So this is the basic thing. Okay. And a specific age group in which there is risk of hypothermia and care needed, how will you anticipate? You will maintain the temperature. You will be giving warm fluids. You will be giving mattress. You will be covering the patient, bear hugger, things like that. Okay. So similarly, airway plan I have discussed with you, spine examination. If you have a patient with risk of IV cannulation, like if you have a pediatric patient or elderly patient, IV cannulation may be difficult. Okay. Drug addict, IV cannulation may be difficult. Patient with rheumatoid arthritis, contractures, cerebral palsy, spastic cerebral palsy, IV cannulation may be difficult. Things like that. Okay. And then you have to try the fit multidisciplinary team. Okay, if you have a patient with placenta previa, you need multidisciplinary teams, like you need hematologist, blood bank. You may need discussion with the intervention radiologist. They may be putting balloon in the internal iliac vessel. Okay, so that if the bleeding is not controllable, they are doing the embolization. Okay. Similarly, placenta accreta, there may be involvement of the gut. So general surgeon, urologist, there may be involvement of ureter. Okay. So this is the concept of multidisciplinary team. If you have a patient with on warfarin, you will be involving the anticoagulation team or cardiologist. If you have a patient with any condition in which hematologist is required, you will be consulting hematologist. Things like that. Okay. So in every patient, you just try to find out any multidisciplinary team needed or not. Maybe it will be needed, maybe it will not be needed. Okay. And this we have discussed before, duration and positioning. Position related problems I have already discussed with you multiple times, the lithotomy and everything. Okay. Pre-medication plan, you want to give it or you don't want to give it. There will be certain patients in which you will avoid it, like patient with airway collapse. Like for example, if you have a obese patient in which airway may collapse, so you will not give, you will be giving it titratedly. Any patient in which there are chances of hypercarbia or hypoxia, you will try to give it titrated doses, or you will be using it cautiously. Okay. So similarly, plan related monitoring, any special investigation needed, care needed. Okay. So that's what my aim was. Similarly, extubation plan, blood management, blood loss, or any blood conservative strategies I've discussed with you multiple times, that how to conserve the blood, hemodilution, cell saver, avoiding hypothermia, antifibrinolytic, okay, positional strategies, hypotensive anesthesia, okay, minimum invasive surgical or anesthetic technique, okay. So things like that. Okay. So I hope this session was useful for you people. Any question, any comments anyone wants to ask?
Sir, I have a question.
Yes.
Sir, if what if I don't know any answer of any question, what I have to reply? That should I pass that question, or I ask him to ask later? What I have to do?
You know, if you are like for example, if you have no idea, of course you have to pass it rather than wasting time. Okay, because one question will not fail you. Okay.
Yes, sir.
Yes, Dr. Dora.
Hi, any special recommendations for EDIC part 2 test?
I'm sorry, I couldn't understand. Can you repeat, please?
Do you have any recommendations for EDIC test?
Your European diploma and anesthesia intensive care. You know, I did it in 2016. Okay. And I tell you something, it was not difficult, but it was one of the most enjoyable exam for me. Why I'm saying this thing? That the questions being asked were very compact and very logical. Like, for example, I'll give you an example that in any other exam, they will never ask you this question. Like they asked me a question which actually inside at that time, I was not aware of the good actual answer. But that time they asked me related to pain, that when I pinch, that just put, you just show that she showed, the examiner showed me that when I'm pinching myself here, there is a pain and how it is being transmitted to the brain. So it's from where she started. And then she said how it is being transmitted. And then how, what, and then I told told her the pain, that there are 4 steps: transduction, transmission, modulation, perception. And then she goes further, and believe me, in 4 or 5 minutes, I was able to tell her whole pain management. Believe me, she extracted, because I maybe if she were asking me details of radio frequency ablation, maybe I was stuck. Okay. But it was a conceptual question in which she wanted me to evaluate that what are the different therapies. And similarly, there was a question on ICU. And in one question, believe me, they extracted knowledge about sepsis, ARDS, VAP, infection, even infection control, how to prevent infections. So if you ask me about EDAC, the basic sciences component, people are afraid. They think that they are asking question basics for basics. So because EDAC exam is not as deep as primary FRCA. Okay. Because in primary FRCA, if you want to make yourself crazy, primary FRCA is the ultimate exam. Because in primary FRCA, they will be asking you about Wheatstone bridge. If they are wanting to ask you about intra-arterial blood pressure monitoring. But if you are going to IDAC exam or Irish fellowship exam, they will be maybe asking you what are the different information you can extract from the waveform of the intra-arterial blood pressure, that how can you say that this patient has low SVR, or this patient is hypovolemic, or this patient contractility is not good or bad. So the depth of questions being asked is like that. They will be asking you one question about basic sciences from physiology. Like one possible question is that, like the question which I was being asked, and in that question, he asked me everything, but it was about how blood pressure is maintained. And then the examiner asked me about what are the different factors, and then they go towards cardiac output, and then they take me towards different types of heart failure: right-sided versus left-sided, compensated versus decompensated, high output versus low output cardiac failure. So actually, if you ask me about EDAC, the EDAC exam is very methodical. Okay, I was afraid that they will ask me to draw the graphs. And if they had asked me to draw the graphs and they had failed me on that, maybe because I am very bad in graphs. But the bottom line is that even if you are not able to draw the graphs, if you are able to explain the concept, like they will be asking you, one of the question will be that, can you correlate the electrical changes, the mechanical changes, and the cardiac cycle they ask some people, if maybe some examiners, they will be asking you to draw specifically. But if you are able to make them understand that what is the correlation of this CVP waveform and electrical activity in the form of this ECG, and the contractilities which actually occurring in the form of the pressure changes with reference to cardiac cycle, they will not fail you. Okay. So this is some about base physiology. In pharmacology, this is a question which they are repeatedly asking. Take one inhalational agent, compare it with other, and they will be starting from the physical properties, the mechanics, the onset, the induction speed, the metabolism, the recovery with reference to inhalational agent. And with reference to IV, the similar question they ask. They take one IV agent and compare it with the other IV agent. Okay. Local anesthetic, take one local anesthetic, compare it with other local anesthetic. So these are the commonly asked questions. I have actually a file in which I have compiled the questions related to European diploma in anesthesia and ICU, and you can find it in the Viva scenarios. It's right there. I will just show you. Okay.
Thank you very much.
Just a second. Actually, you know, it's been an honor for me. You are Dora, just to recall me because I forgot. Where are you in Europe at the moment?
I'm in Croatia.
Croatia. Okay. So
Yes.
yes, I don't know where I put it. I will share it with you. It was somewhere here. Yes, I think it should be here.
Okay.
Okay.
Thank you.
This is here, right here, smiling at you. Okay. Okay. So, oh my God, I'm sorry. I did not share. You know, I did not share the screen. I'm sorry. I did not share the screen. It's here. I will show you again. Okay, so if you go to this Viva, this link, and then you go to the top. I'm sorry, this one. Go to Viva scenarios. Okay, and then in miscellaneous, you will find it here. Okay.
Yes, I see it now. Thank you.
So, okay, everyone. Thank you very much. Okay, Sahrish, Azhar.
Yes.